In this class, I shall be talking about induction of labor. I am Dr. Olushola Fashuba. In this lecture, I will try as much as possible to define what induction of labor is. We shall talk about the indications. We shall talk about the prerequisites for induction of labor. And then we shall also discuss the induction of labor itself and its complications. At the end of this lecture, I will expect you to be able to define induction of labor and other related terms. And also, I will expect you to make a list of indications for induction of labor and the methods of induction of labor. Then you must be able to discuss a plan for the induction of labor and then make a structured plan for induction based on clinical condition of each woman. Induction of labor is a frequently performed obstetric intervention, the frequency of which varies from one healthcare facility to another, even within regions and within countries. It is performed only when it is considered that there are benefits to the baby or to the mother compared with the alternative of the baby remaining in utero. In well-selected women, induction of labor is useful and safe, and if done incorrectly or inappropriately, unnecessary risks may be encountered. The rates of induction of labor have increased over a 10-year period. In the United Kingdom, for instance, from about 15.4% in 2003 to 2004 to about 21.2% in 2013 to 2014. In Nigeria, the rate of induction is about 12.7%. Actually varies between 10 to 15% across the tertiary hospitals in Nigeria. 10 to 15%. What is induction of labor? The induction of labor is defined as the artificial initiation of labor after the age of viability for the purpose of achieving a vaginal birth in a pregnant woman who is not in labor. The artificial initiation of labor after the age of fetal viability for the purpose of achieving vaginal birth in a pregnant woman who has not fallen in labor. Augmentation of labor is another related term that we need to define. Augmentation of labor is the enhancement of contractions in a pregnant woman who has already fallen in labor. As opposed to the first one, induction of labor, the woman has not fallen into labor. There is no contraction at all. But in augmentation of labor, the woman has already started contracting. Cervical ripening is another related term that we need to look at in induction of labor. Cervical ripening is the use of pharmacologic or other means to soften effacement or dilatation of the cervix to increase the likelihood of a vaginal delivery after labor induction. It's the use of pharmacologic or other means to soften or efface or dilate the cervix to increase the likelihood of a vaginal delivery after labor induction. And then stimulation of labor also is loosely used to refer to the artificial initiation of uterine contractions when membranes have already ruptured. Stimulation of labor is appropriate when the fetal membranes have already ruptured and you are using some pharmacological agents to artificially initiate uterine contractions. What are the indications for induction of labor? Indications for induction of labor could be maternal or fetal or fetal-maternal. Indications could be maternal or fetal or fetal-maternal. Maternal indications include conditions like prolonged pregnancy. Prolonged pregnancy. When the pregnancy is prolonged, we are talking about pregnancies that have exceeded the due dates, have exceeded the 40 weeks or more, or approaching a post-term pregnancy. Prolonged pre-labor rupture of membranes is another indication, maternal. Prolonged pre-labor rupture of membranes. 3 pregnancy-related conditions, for instance, gestational hypertension, pre-eclampsia or eclampsia, and some intrahepatic liver diseases, could be a reason for induction of labor. Medical conditions such as diabetes mellitus, chronic hypertension, renal, respiratory, and cardiac diseases are some other indications for maternal indications for induction of labor. Fetal indications will include conditions like intrauterine growth restriction, resource isoimmunization, unstable lie, or sometimes intrauterine fetal demise. These are common fetal indications: intrauterine growth restriction, resource isoimmunization, intrauterine fetal demise, and perhaps on unstable lie. What are the contraindications to induction of labor? Contraindications could be relative or it could be absolute. Relative, in which case you may want to balance it and try to see if your induction of labor could be successful. But they are not absolutely contradicted. These are relative. For instance, in certain cases of previous lower segment transaction, one single lower segment transaction, an induction of labor can still be carried out. In multiple pregnancy, grand multiparity, in breech presentation, and elderly primigravida, in all these circumstances, induction of labor can be carried out relatively with very, very close monitoring. Absolute contraindications include contracted pelvis, abnormal pelvis, major placenta previa, persistent abnormal lie, or malpresentation, where there is a pelvic tumor, like a uterine fibroid or ovarian cyst, invasive carcinoma of the cervix, previous uterine scar. For example, one classical cesarean section, that's a vertical incision on the uterus, from the body of the uterus down to the lower segment. Or 2 or more lower segment cesarean sections, myomectomy with endometrial breaching. Then active genital herpes infection and previous successful vesicovaginal fistula repair. All these are absolute indications. For instance, if you do induction of labor in a woman with a contracted pelvis, you are more likely to end up with obstructed labor or prolonged labor with maternal and fetal consequences. Also, if there is a major placenta previa, you are not likely to achieve success, but a disaster. Where there is invasive carcinoma of the cervix, it's possible that you can provoke further hemorrhage that can lead to the death of the woman. Where a classical cesarean section has been done previously, or where there is a two or more lower cesarean section has been done, or mammectomy with breached endometrium, it can lead to rupture of the uterus with a lot of consequences. Then, with active genital herpes infection or previously successful vaginal fistula repair, the vaginal fistula repair could break down, and then the woman can also begin to have a repeat VVF, with a lot of problems. What conditions? What are the prerequisites for induction of labor? What are the prerequisites for induction of labor? The first thing that we must know is that the fetal maturity must not be in doubt at all. The fetal maturity must not be in doubt. The gestational age of the fetus must be ascertained from the date of our last menstrual period, or from an ultrasound confirmed ultrasound confirmed date, particularly ultrasound dating from the first trimester, may help in ascertaining the gestational age of this patient, of the fetus. Again, in determining the maturity from gestational age, one must also take into cognizance the maturity of the lungs. Maturity of the lungs. But in our environment, if the gestational age is more than 36 weeks, we can be absolutely sure that the fetal lung maturity is likely to be satisfactory. And where there is facility, amniotic fluid analysis determining the lecithin sphingomyelin ratio that is greater than 2 will give absolute evidence that that fetal lungs is matured, and induction of labor can be successfully carried out. We must also confirm the fetal health, the fetal well-being. We must also confirm the fetal well-being using cardiotochographs or amniotic fluid index or a biophysical profile, or using umbilical artery Doppler waveform analysis. These 4 investigative parameters will predict the fetal well-being successively. Because it's very important that the fetal well-being is assessed before induction of labor. Because you may see an adult person in 5 minutes, and before he treks about another 1 kilometer, you may hear of the man falling down and die. So it's also important because we are going to put the fetus on stress, and therefore it's important that we assess the fetal well-being and ensure that it's very, very accurate. One other thing that we must ensure that is present is the adequacy of the pelvis. Adequacy of the pelvis. You remember I said one of the absolute contraindications is contracted pelvis. So the pelvis must be adequate. The clinical assessment of the pelvis must be done, and sometimes you may have to do a radiological pelvimetry to ensure that the pelvic is adequate, that there is adequate in size and dimensions and shape as well. And fourthly, the cervix must be found suitable. The cervix must be adjudged to be very suitable for induction of labor. And finally, you must ensure that there are facilities for fetal-maternal monitoring and emergency for an emergency abdominal delivery. These conditions must be satisfactory, right, before we carry out an induction of labor. The conditions again are: 1, the fetal maturity must not be in doubt. The fetal well-being must be very adequate. The fetus must be of average size, and there must not be any contracted pelvis, and the cervix must be suitable for induction. How do we make the cervix suitable for induction? And this is where the subject of cervical ripening comes in. Cervical ripening is an important force component to labor induction. It's an important force component to labor induction. Prior to spontaneous labor, the cervix begins to soften over time, and the connective tissue components of the cervix are extensively remodeled, which is also known as cervical ripening. And this process of cervical softening and probably effacement is brought about by the release of prostaglandins at the decidual bed of the endometrium. In the labor ward setting, mechanical or pharmacological agents can be used to cause cervical ripening. Mechanical or pharmacological agents can be used to cause cervical ripening. The process of cervical ripening by itself alone may, however, stimulate labor. And if not, if the process of cervical ripening does not stimulate labor, therefore it may be an addition to add a further pharmacologic agents like oxytocin. Generally, cervical ripening and induction of labor are on a continuum, and not all women undergoing induction of labor need cervical ripening. Not all of them. Not all of them, because in the initial assessment, it's possible that the cervix has been fully prepared by the natural prostaglandin released from the decidual beds. Labor induction with an unripe cervix will require more uterine activity to effect cervical dilatation, potentially causing a longer labor, more pain, and stress for both mother and baby, with a higher risk of uterine rupture and evidence of an increased risk of delivery by cesarean section. So at all times, to avoid failure of the induction of labor, we must ensure that the cervix is ripened. Because if not ripened, if the cervix is very long and it's not effaced, therefore, more stress will be caused to the mother and the baby. The mother may experience a prolonged labor, may experience more pain than necessary. In cervical ripening, it's possible you must have to do what we call a Bishop scoring assessment to determine if the cervix will be favorable or unfavorable for induction of labor. The Bishop scoring can be used to determine if the cervix is favorable or unfavorable. If you do that scoring, a score of 7 out of 13, a score of 7 or more out of the 13 scores is favorable. And if you have a score of 4 or less, that shows that the cervix is unfavorable. A score of 7 out of 13 or more, a score of 7 or more out of 13 score is favorable. A score of 7 or more out of 13 is favorable. A score of 4 or less is very unfavorable. If you have a score of between 4 and 7, then you may have to wait a little bit, or you do the score again and see whether or not, to see whether the cervix, to see whether you need a cervical ripening or not. When a score of service, a score of the bishop score is more than 7, there is no need for a cervical ripening. There is no need for a cervical ripening. But if it's less than 4, there is a need for cervical ripening. What is this bishop score about? In the bishop score, we are scoring 5 parameters. We are scoring cervical dilatation. We are scoring the cervical length, which is the effacement. And we are scoring the station of the presenting part in the pelvis. The station of the presenting part in the pelvis. We are scoring the consistency of the cervix. And we are scoring the position of the cervix in the pelvis. 5 parameters: cervical dilatation, cervical effacement, station of the presenting part, and consistency of the cervix and position of the cervix. So if you look at these 5 parameters, one of them, 4 are related to the cervix and 1 is with the station of the presenting part. You score over a score of 3, 0, 1, 2, 3. If the cervical dilatation is 0, if the cervix is closed, it scores 0. If dilated to about 1 to 2, it scores 1. And if the dilatation is about 3 to 4, she scores 2. And if cervical dilatation is greater than 4 cm, then you score 3. Total maximum mark 4. When the cervical length is greater than 4, that means the cervix is still normal, is still remaining its normal length. She scores 0. If the cervix is between 3 and 4, if the cervix length is between 3 and 4, she scores 1. If the cervix is between 1 to 2, she scores 2. And if it's less than 1, she scores 3. If the cervix is between 1 to 2, that means about almost the length of the cervix has reduced to about 50%. And less than 1 centimeters. That shows that the length of the cervix is just about 25% of its normal length, and that makes the cervix more favorable. The station of the presenting part, that's the level of the descent of the fetal head in the pelvis. The level of the descent of the fetal head in the pelvis. If the head of the fetus is at -3 station, that means there is no descent at all. So scores 0 there. If -2, at -2, there's a distance about -2 above the ischial spine. Therefore, it scores 2, it scores 1. And between -1 and 0, that means at the level of the ischial spine. So it scores 2. And if it is +1, that is the level, the presenting part is below the ischial spine or even more down. So this woman will score 3, maximum 3. Cervical dilatation, cervical effacement, and station of the presenting part have a maximum score of 0 to 3. Whereas these last 2 that I'm going to mention, the consistency of the cervix and the position of the cervix, have a maximum score of 2. So, consistency, whether the cervix is firm or soft. If the cervix is firm, she scores 0. But if it's medium, not firm, not soft, medium, she scores 1. But if the cervix is soft, she scores 2. The same thing is the position of the cervix in the pelvis. If the cervix is posterior, she scores 0. If the cervix is mid, at the medium level, mid position between the anterior and posterior, she scores 1. And if it's anterior, the woman scores 2. So if you look at the total score, we are talking about a score of 13. And when we say a cervix is favorable, we must be able to achieve a score of 7 and above before we say this cervix is favorable and to be suitable for induction of labor. And if this total score, you score this one and it's less than 4, then we can say this service is not favorable. It's not favorable. This is what we call the modified Bishop score. What are the other methods of cervical ripening? What are the other methods of cervical ripening? Yes, we can use mechanical methods. We can use mechanical methods for cervical ripening. One is the use of osmotic dilators. Osmotic dilators. Example of this is the laminaria tent or the Lamicel. This laminaria tent is just inserted into the canal of the cervix. They are hydrophilics. They have hydrophilic properties. They absorb water from the cervix and then they swell up. In the process of swelling up, they cause a dilatation of the cervix and softening. The other mechanical methods that we can use apart from osmotic dilators like the laminaria tent is the transcervical extraamniotic Foley's catheter. In many circumstances, we always insert cervical catheter size 16 to 18 into the cervix and push it up and blow it with about 30 to 50 ml of normal saline. In the process, the amniotic membrane is displaced, and there could be release of prostaglandins. There could be release of prostaglandins from the amniotic bed. And sometimes again, we can infuse extraamniotic saline solution, but it's no longer recommended. Yes, but these osmotic dilators and transcervical extraamniotic fluid Foley's catheter are still well practiced and they give good results. And sometimes again, as part of the mechanical methods, if the cervix is fully dilated, you can do what we call a sweeping membrane, and the same practice try to stretch the cervix with both the middle finger and the index finger of the right hand. That is also a good method. If possible, the cervix, if one finger can enter the cervix, you can do sweeping of the membrane and then use the fingers to mechanically simulate cervical ripening. Then there could be other methods of pharmacological agents. Prostaglandins, which I've mentioned, prostaglandins, mifepristone, nitric oxide, and intracervical hyaluronidase. The typical examples of prostaglandins that we have in circulations are the misoprostol that we now use for our cervical ripening. Misoprostol. Yes. I've talked about these osmotic dilators. I said the typical examples are seaweed, Laminaria japonicum, and other synthetic compounds like Lamicel and dilapan. They directly cause cervical dilatation by releasing endogenous prostaglandins and oxytocin. Yes. The dilators are hydrophilic, such that they absorb water and enlarge the cervix, which in turn causes the cervix to dilate. Data regarding the efficacy of these dilators for induction of labor are mixed. Studies have shown an increased rate of infection with laminaria use, resulting in chorioamnionitis, endometritis, and neonatal sepsis. Yes, studies have shown that some of these can lead the catheter we have talked about. The catheter, the laminaria tent, can cause an increased risk of infection, resulting in chorioamnionitis, endometritis, and neonatal sepsis. These are the examples of osmotic dilators. These are examples of this, and they come in different sizes. come in different sizes. And you can see the position where is put in the cervix. When it swells up, it softens the dilated cervix several hours later. And what you normally do when you want to do this, these osmotic dilators can be put overnight. If the induction is to be carried out in the morning at about 5-6 a.m., the osmotic dilators can be inserted maybe about 10 hours or 12 hours previously, or even 24 hours after. And you can see how the osmotic dilators swells up and dilate the cervix. The same thing transfers cervical catheters, which I've mentioned above. The balloon works by mechanically dilating the cervix after ballooning it with about 30 to 50 minutes of normal saline and stripping the membrane, stimulating endogenous prostaglandin release. This you can see from this from the diagram. You can see the position of the cervix. You can see it's placed extra amniotically. And sometimes two catheters can be used, one above the other. One can be in the cervix and one above the internal horse. But again, the available data has not shown that a double catheter is superior to a single catheter. Double catheter is not as superior as a single catheter in causing ripening of the cervix in induction of labor. Yes, the prostaglandins. The prostaglandins typically, an example of it is misoprostol. Prostaglandins are produced in the decidua or in the myometrium, resulting in uterine contractions. Synthetic prostaglandins can be given for cervical ripening and labor induction. They are very highly effective, but their cervical ripening effects cannot easily be separated from their stimulatory effect on uterine contractions. Their cervical ripening effects cannot be easily separated from their stimulatory effect on uterine contractions. Yeah, the prostaglandins, they tend to sensitize the myometrium. Before the induction of labor is actually carried out. Tends to sensitize the myometrium. So, prostaglandins reduce the risk of woman not being delivered within 24 hours of the start of induction. And they reduce the requirement for cesarean section, but increase the risk of uterine hyperstimulation with fetal heart rate changes. Prostaglandins, they reduce the requirement for cesarean section. They also reduce the requirement for high-dose oxytocin and increase the risk of uterine hyperstimulation with fetal heart rate changes. Like I said, the commonly used prostaglandins are misoprostol and dinoprostone. Misoprostol is a synthetic prostaglandin E1 analog that has been found to be safe and inexpensive agent for cervical ripening. Misoprostol is a synthetic prostaglandin E1 analog that has been found to be safe and inexpensive agent for cervical ripening. Usually, they can be administered vaginally, oral, buccal, or subliqueal route for induction of labor. But in most places, vagina and the buccal routes are preferred routes for administration of misoprostol. The typical dose for intravaginal dose is 25 micrograms every 3 to 6 hours. The typical dose for intravaginal misoprostol is 25 micrograms every 3 to 6 hours. Slow release intravaginal 200 micrograms released at a rate of about 7 micrograms per hour over 24 hours have also been proposed. But the risk of hypertonic stimulation of the uterus is high with this dose. Larger research studies are needed before routine use of buccal or sublingual administration. This dose cannot be controlled as such. Dinoprostone is a synthetic prostaglandin E2. It's available in several forms, but they do not find favor as misoprostol in our environment. They come in tablets, gel, and control-release pastry as well. Misoprostol, you compare misoprostol versus dinoprostone. Misoprostol is cheap, is readily available, and can be stored at room temperature. Misoprostol is cheap, readily available, and can be stored at room temperature. The effects of vaginal or oral prostaglandin E1 are similar to those of prostaglandin E2 when placebo is used as direct comparator of fish. However, direct comparison between vaginal prostaglandin E2 and vaginal misoprostol shows that labor induction with vaginal misoprostol is associated with a lower likelihood of vaginal birth not occurring within 24 hours and a trend to a greater risk of uterine hyperstimulation with fetal heart rate changes. And indirectly, it means that the misoprostol seems to be more effective to dinoprostone. Transvesical catheter versus prostaglandins. Yes, vaginal misoprostol was the most effective cervical ripening method to achieve vaginal delivery within 24 hours, but had the highest incidence of uterine hyperstimulation with fetal heart rate changes. The use of a Foley's catheter to induce labor was associated with the lowest rate of uterine hyperstimulation accompanied by fetal heart rate changes. So, if you want to avoid, particularly in a multipara, and you want to induce labor, so it's better to use a Foley's catheter to do your cervical ripening because it is less associated with hyperstimulation of the uterus. Labor induction. We have defined what labor induction is. We have also talked about the indications and contraindications of induction of labor, and we have talked about the conditions necessary for us to do induction of labor and how to prepare the service for induction of labor. Then how do you now carry out this induction of labor? How do you carry out this induction of labor? Once the service is ripe, continuation of labor induction can be commenced. Once the service is ripe, then what are the methods that we normally use? They are both medical and surgical methods of induction of labor. So there is no such artificial boundary between these two methods, between medical and surgical induction. The surgical induction refers to amniotomy, where the amnion is broken to release some of the liquor. That alone can simulate labor because of the release of prostaglandins from the amniotic cavity itself and from the decidual bed. The major pharmacological agent that we use in induction of labor is oxytocin. And we can also do a membrane stripping as I've said earlier, membrane stripping and digital and sweeping of the membrane, and then trying to see whether you can digitally dilate the cervix. Amniotomy is a surgical procedure to rupture the amniotic membrane. It may augment contractions and shorten the duration of labor. It may augment contractions and shorten the duration of labor. It may be combined with oxytocin infusion to facilitate uterine contractions. And water rupture is done with amnio hook or Coca's forceps. Water rupture is done with amnio hook or Coca's forceps. Precautions in doing amniotomy. It's always better to listen to the fetal heart rate before the amniotomy is done. Listen to the fetal rate before and after the procedure, because there may be some fetal heart rate changes that could necessitate abandoning induction of labor for cesarean section. A pelvic examination should be performed to evaluate the cervix and section of the presenting part. A pelvic examination is performed to evaluate the cervix and section of the presenting part, and the head must be engaged. The presenting part must be well fitted to the cervix. At the same time, the clinical pelvimetry done to ensure adequacy of the pelvis and shape of the pelvis. The membranes are identified, and the amnio hook is inserted through the cervical horse by sliding it along the hand and fingers, and the bulging membranes are ruptured. This is the procedure of doing the amniotomy. You can see the two fingers guiding the amnio hook or Coca's to reach the bulging membrane, and the bulging membrane is just, with the amnio hook, just puncture it, and the fluid starts to come out. And when you do this amniotomy, one should clearly observe the color of the liquor coming out. The quantity is very important. Look at the quantity coming out. Is it much? Then after you have done the rupture, just keep your finger there and do a controlled amniotic fluid. The fluid should be guided coming out to avoid abruptio placenta, and again to feel if the cord can come out with the gushing out of the amniotic fluid. So it's control the amniotic fluid with the head of the finger, and then if that one is not done, it can lead to cord prolapse or abruptio placenta. Yes, after this has been done, after amniotomy has been done, and usually what this synthetic oxytocin is put inside a 500 ml of dextrose water before the amniotomy. Yes, so the oxytocin usually is we tend to use about 5 international units of oxytocin in 500 ml of dextrose water, and suggested starting dose range from 5 to 6 milli international units to a maximum of 32 milli international units. Practically, what we do is to put 10 international units of oxytocin in 1 liter of saline, starting at 10 drops per minute, and increase by 10 drops per every 30 minutes till adequate contractions are noted. At least we talk of adequate contractions, about 3 contractions in 10 minutes, lasting 40 to 50 seconds. That's a normal contraction. So until adequate contractions, 10 units of oxytocin in 1 liter of saline, and starting titration with 10 drops per minute, increasing by 10 drops per minute every 30 minutes till contractions are adequate. And I said adequate contractions is about 3 contractions in 10 minutes, lasting 40 to 50 seconds. So is also while doing this oxytocin is always, we should aim at delivery of this fetus in less than 12 hours with oxytocin induction. Oxytocin induction should not be started within 6 hours of the activation of prostaglandins. So we assume that you have put the prostaglandins overnight. If you are going to start induction in the morning, about 5, 6. So we expect that the prostaglandins should have been inserted between 8 and 10 p.m. of the previous night. And where we have this, when you have oxytocin on, facilities should be available for continuous electronic fetal monitoring and uterine contraction monitoring. And once active labor is established, monitoring should be done with a pantograph, and adequate analgesia should be ensured, preferably with epidural. The process I have described is the gravity method of titrating oxytocin. But ideally, we should use an auto-regulating infusion pump, like the type described by Cardiff. Using this auto-regulated infusion pump, you are likely to prevent hypersensitivity of the uterus. We are likely to prevent that, and it's likely to reduce more stress for the fetus and the mother. What are the complications of induction of labor? What are the complications of induction of labor? Induction of labor can fail. So that's the most common thing. Can fail for many reasons. Can fail because the cervix is not fully dilated. The cervix is not well prepared. It can fail because there is disproportion between the pelvis and the fetal head. It can also fail because of unrecognized malpresentation or an abnormal lie. So that's the first thing that we must know. It can fail. And for you to avoid failure, you must thoroughly assess the fetus and the mother when you are considering induction of labor. Secondly, there could be uterine hyperstimulation. Where you combine prostaglandin and oxytocin, the chances of hyperstimulation increases. And this should be avoided in a multipara who has a higher chances of uterine rupture during induction of labor. There could be a precipitate labor, in which case we are thinking of achieving induction of labor within 6 to 8 hours. But we can achieve a precipitate labor can occur, contraction is rapid, and within 2 to 4 hours, the woman has reached full cervical dilatation. So we must try and observe this for precipitate labor. There could be water intoxication, particularly if you are giving too much of fluid. Water intoxication is, you have to, if monitoring is not care, you can find out if monitoring is not adequate enough, then you can experience some water intoxication. Uterine hyperstimulation, precipitate labor can lead to uterine rupture, so which is a major complication, particularly in a multipara. Again, you can have primary postpartum hemorrhage complicating induction of labor, and puerperal sepsis, as I explained, as when you insert your laminaria tent, the osmotic dilators or catheters, you can introduce infection that can lead to choroamnitis or puerperal sepsis or neonatal sepsis later on. There are some fetal complications that may follow induction of labor. The first is iatrogenic prematurity, and that is the major complications involving the fetus. If your maturity is not well determined, the last menstrual period, the gestational age is not ascertained adequately, you can induce a premature labor. And all the complications of prematurity the baby will face. Iatrogenic prematurity is a major reason, it's a major complication for induction of labor, and this must be avoided at all costs. There could be fetal distress arising from hypertonic uterine contractions using a combination of prostaglandins and oxytocin. And following the rupture of the amniotomy, following amniotomy, you can have a cord prolapse, you can have abruptio placenta, and later on you can have neonatal sepsis. Uterine hyperstimulation occurs in about 1 to 5% of women undergoing induction. Uterine hyperstimulation may occur in 1 to 5% of women undergoing induction. And it occurs when it's accompanied by abnormal, it can occur with abnormal fetal heart rate pattern, or the hypertonic uterine contractions, hypertonic stimulation can occur and be accompanied by abnormal fetal heart rate pattern. And when this type of thing occurs, when this uterine hyperstimulation occurs, it can be subdued by giving 0.25 milligrams of tabutalin to ameliorate it. Can be suppressed by subcutaneous tabutalin, 0.25 milligrams IV. Failed induction of labor occurs in about 50% of primigravida with an unfavorable cervix, but less commonly in multiparous women or those with a higher Bishop score at the start of the induction process. So this failed induction may be defined as failure of labor to start after one cycle of treatment. It has also been defined as failure to achieve vaginal delivery after induction has been initiated. So what do you do after this? If induction fails, healthcare professionals should discuss this with the woman and provide support. This woman should know that the process has failed, and then the alternatives should be discussed with her. The woman's condition and the pregnancy in general should be fully reassessed and fetal well-being also assessed. The subsequent management options include a further attempt to induce labor. The timing should depend on the clinical situation on the woman's wishes. But usually, when you say you want to do a second attempt, it may cause some anxiety for the mother. And it is always better to abandon the failed induction, because the chances of a failed induction will be very critical to the woman. And it's always important to do a cesarean section. Induction in previous cesarean section. This must be cautious. You must be able to be careful about this. It should not be done where a classical cesarean section has been done, or where 2 or more cesarean sections has been done. But one previous cesarean section, yes, it can be done. It can be done with all caution. Then there must be facilities for emergency delivery, and there must be facilities for fetal monitoring when you want to embark on the induction of labor following one previous cesarean section. Yes, Foley's catheter may be in this type of in previous cesarean section. Prostaglandins should not be used for cervical ripening. If at all is going to be used, the dose of this should be reduced to minimal. The dose of it, because of the risk of hyperstimulation of the uterus that can lead to ruptured uterus. Foley's catheter may be a better choice, given the reduced risk of hyperstimulation. What about induction of labor in certain conditions like diabetes mellitus? Yes, induction of labor is very safe with diabetes mellitus, provided that the fetal maturity is adequate, that the fetal head-beam is alright. What we need to do in the process of induction of labor in the labor room is to ensure that the fetus and the mothers are well managed, that epidural analgesia is given, and that at the time in the morning of the induction of labor, the half dose of the daily requirement of insulin is given. The half dose of the daily requirement is given, and a rapid insulin, about 6 million international units, is added to the 500 ml of 5% dextrose in water and titrated against the result of the capillary blood sugar obtained from records of the glucose using a glucometer. You do that every hour and it can be titrated. The insulin dose can be titrated. So if all these measures are taken, the woman should have a successful delivery in the absence of a contracted pelvis or in the absence of a plethoric baby that may constitute a cephalopelvic disproportion. Induction of labor, in summary, induction of labor is a common obstetric intervention in modern day practice. The indication and gestational age must be confirmed before commencement, and the chances of success are higher if the service is favorable. Detailed assessment of the patient must be carried out in order to ensure selection of the appropriate mode of induction. I thank you for listening.